3, so we have to do a local staging workup as well as an metastatic workup. So in small tumor, you don't have to do an exhaustive workup. Stage 1 and 2 is curable by a single modality treatment itself, and stage 3 and 4 need multidisciplinary treatment, which I will be telling in short while. So the stage determines the prognosis. As the stage progresses, the prognosis is very grim. Coming to the treatment part, the standard treatment of all diseases apply to cancer also. So we aim to cure sometimes and we treat often, but the uh, final basic outline will be to comfort always. So in early stages, like I told, it will be a single modality treatment, and in only advanced stage, multimodality treatment comes. So what I mean by this is, if we identify the cancer as a stage 1, we cure with one modality alone, either a surgery or radiation. So for a stage 1 breast cancer, surgery alone is curative. For a stage 1 endometrial cancer, surgery alone is curative. Stage 1 RCC, surgery alone is curative. Stage 1 tongue cancer, surgery alone is curative. We don't get confused, should we have to give chemotherapy or radiotherapy in addition. For an early stage, if we catch them early, only one modality enough for a cure. Only when we go for advanced stages like stage 3 and above, we need multimodality treatment. The standard multimodality treatment, which includes all the three pillars of oncology, surgery, chemotherapy, and radiotherapy. When there are recent advances in chemotherapy, which includes targeted therapy, immunotherapy, and they have proven their role in prolonging the lifespan of the patient in advanced cases. So surgery is an age-old proven treatment modality for all solid cancers. If you identify it early, surgery alone is curative. It offers cure and immediate symptom relief in early cases. It takes care of local diseases and it gives symptomatic relief in advanced cases. Like if it's a bleeding ulcer or is a fungating tumor, surgery offers good symptom relief. There are several recent advances. I will just like to point out a few recent advances in surgery. Now the goal of oncology has moved from radical surgery to conservative surgery. We offer the same cure, but we do conservative surgery. Like we used to offer MRM for all cancers which are curable. Nowadays, for early breast cancers with suitable criteria, we offer breast conserving surgery. Sentinel node biopsy is a new concept which has come up in surgical oncology and is being employed in several subsites. And surgical oncology has advanced leaps and bounds in the field of minimal access techniques, and the arrival of robo has helped us great in this part. So this is that case which I have told, where the scar is inappropriately placed. We managed to conserve that breast by excising it with adequate margins all around. And this patient had a breast conserving surgery followed by radiotherapy and is symptom free for the past 6 years. So the second advancement which I told is a sentinel node. What is a sentinel node? It is the first node which drains the lymphatics from the tumor. The node which receives the lymphatic supply as the first station is the sentinel node. So if the disease has to spread, then it has to cross the node and then go to the nearby nodes, and subsequently the spread happens. So if you can identify this node at the initial stage itself in the planning treatment, if the node is negative, then we do not have to plan the further dissection of these nodes. So the main morbidity of a mastectomy, for instance, is the seroma formation and lymphedema. This is attributed directly to the extent of the node dissection. So if we can avoid this node dissection, if we can prove that this node is negative at the initial onset, then we can avoid the morbidity associated with axillary node dissection. Similarly, we can identify the sentinel node in the head and neck case, then we can avoid the neck dissection for those cases. In endometrial cancers, if we can identify the sentinel node and prove that it is negative, then we can avoid the pelvic node dissection and para-aortic node dissection, thereby limiting the morbidity. So how we can go about this? So this sentinel node is identified by injecting several dyes into the tumor or in the peritumoral area, and we trace these dyes to the first draining node. We remove that node, subjected it to histopathological analysis on table by frozen section. And if we can prove that that node is negative, the axillary dissection or the lymphatic dissection, node dissection stops there itself. So this is a methylene blue dye which we use for a visual cue. This dye is injected in the peritumoral area or intratumorally, and this dye is traced to the node. So this is a gamma camera which we use to do the nuclear scintigraphy. Here we inject the radionuclide technetium labeled sulfur colloid is the tracer we use. We inject it on the day of surgery. We take the patient to the nuclear medicine department. There we will scan under the gamma camera and we inject a dye peritumorally or intratumorally, and we get a tracer uptake in the node. This is the primary site and the tracer we can find. And then we use an handheld gamma probe intraoperatively to find where this node is located. So I'll show you a small video. So here an additional dye is injected on table. This is a diluted methylene blue which we inject periorally. This is a case of early CA breast, 2.5 centimeter tumor. We wait for 5 minutes for the dye to reach the lymphatics. Then we open the axilla. This patient has already got the nuclear tracer injected on the day of surgery in the morning itself. This is the second dye being injected. This will provide a visual cue to locate where the node is. We wait for some time, then we open the axilla through a separate incision. We'll try to locate that node which is stained blue by the dye. We use the handheld gamma probe. The same node will receive both the tracer as well as the blue dye. The counts will be displayed on the system. So the node which has a maximum number of radioactivity count is considered as a sentinel node. So the count is simultaneously checked along with the color of the node. So this is the blue dye which shows high radioactivity count. That node is not, node alone is removed. We don't do complete axillary dissection. And we check the count again. Once the count is high, that node is sent to frozen section analysis. We get the result within 20-25 minutes. If we can categorically prove that that node is negative, we will stop the axillary staging procedure. We will not proceed with the axillary dissection. A few words about the radiotherapy. Radiotherapy is another pillar of mainstay of treatment of cancer patients. It provides good local control and eradication of disease. It is also curative in early stage of disease. Like in stage 1 cervical cancer, we just treat with radiation alone. It is equally curative. In stage 1 head and neck cancer, treat with radiation alone. It is equally curative. Once the stage advances, then the role of multiple modalities of treatment becomes essential. So it is curative in advanced stage along with chemotherapy. Suppose in a stage 2B cervical cancer or in a stage 2 or 3 tongue cancer, if we add chemotherapy along with radiotherapy, it is equally curative as that of a surgery. It aims in helps in preserving the organ. Suppose for a stage 3 laryngeal cancer, the treatment will be debilitating with loss of voice, total laryngectomy. For the same patient, if we can treat with the chemoradiotherapy, the same cure rate as that of surgery is achieved with additional preservation of his voice and swallowing functions. So in the role of radiotherapy comes in adjuvant therapy in advanced cases post-surgery. And most cases, it is used for palliative treatment for example, for relief of persistent and chronic pain, for neurological compromise like spinal tumor impinging on the spinal cord causing paraparesis, or any tumor impinging on a nerve causing shooting pain. In those cases, radiation can relieve symptoms. So these are all the several radiotherapy techniques. All the radiotherapy techniques use the same uh, treatment particle, that is the photon. So the broadly it is divided into internal therapy and external therapy. The commonly used radiotherapy which we see is an external beam radiotherapy. Internal intracavitary or internal radiotherapy has got limited indications. So in all the radiotherapy techniques, the standard energy delivering particle is a photon. There are several names which you come across, like an 2D, conformal, 3D, IGRT, IMRT. All the techniques, the energy particle is a photon which is generated using several techniques. In a 2D setting, the cobalt is an energy source which delivers that energy particle. In linear accelerator, the linear accelerator generates that high energy photons. So the name only the how the energy of photon is generated, and the effect remains the same irrespective of the type of radiotherapy. What changes is how the surrounding tissue reacts to that photon. In a 2D RT, the treatment area is very large. So entire tumor along with normal tissue receive the entire dose of radiation. So the side effects are more. With the newer techniques like a conformal RT or a IMRT or a IGRT, it is the sparing of the normal tissue which helps in reducing the side effects of the radiation. So that is the basic difference between techniques of radiotherapy. So more advanced technique we use, we spare the normal tissue from the side effects of radiation without compromising the tumor cell kill. So the tumor is anyway irradiated in all the techniques of RT. The more advanced we go, we spare the normal tissue. This is the Selectron radiotherapy machine which is available in our center. So this gives IMRT, IGRT. So it is very, very highly conformal. So the normal tissue is part of the radiotherapy effect. The third main treatment modality which we have against cancer is a chemotherapy. It is curative. It has curative role in liquid malignancies, and in selected solid malignancies, it has got curative role. Otherwise, the role of chemotherapy in solid cancers is more. The role of chemotherapy in solid cancers is mostly as an adjuvant to either radiation or this based on the principle that drugs act on the cancer cell via different mechanisms. So the Sorry for the interruption. So we usually give a combination chemotherapy because we combine drugs with several mechanisms of action. So it increases the tumor cell kill, and also it overcomes the resistance of the tumor cells to the delivered drugs. So chemotherapy is used in various roles. We use chemotherapy as a neoadjuvant before the treatment proper. And the rationale is to make the non-operable tumors operable, to achieve organ preservation, and to select the sensitivity of specific treatment uh, drugs. And most of the time in solid tumors, the role of chemotherapy is only as an adjuvant to prevent disease from coming back, both locally as well as in the distant areas. And in advanced cases, the chemotherapy has a big role to play. It prolongs the recurrence-free survival as well as increases the lifespan. And And chemotherapy is also used as a induction chemotherapy to potentiate the effect of subsequent treatment proper, mostly is a radiotherapy. And it can be used as a dose intensified chemotherapy. Maintenance chemotherapy and metronomic chemotherapy. So how to prevent cancer? There is no magic pill discovered yet to prevent cancer. What we can do and what we can advise our patients was to maintain a healthy lifestyle. First and foremost thing is tobacco abstinence. So tobacco causes almost cancers in all the organ systems. So abstinence from tobacco is the first step we need to emphasize to our patients, and maintain ideal body weight within the prescribed levels, because obesity has been shown to cause 13 cancers, proven, clinically proven. Obesity is a causative factor for 13 cancers, and it has been implicated in another 10 cancers. So if you can maintain a body weight and be physically active, that itself is a good protective role in cancer prevention. And maintaining a healthy diet containing green leafy vegetables, avoiding red meat, and with a lot of antioxidants, and also to limiting sun exposure in those areas where the incidence of skin cancers is high. This is proven to be a good preventive role. And availability of vaccines against virally induced cancers has helped in getting protection against hepatocellular carcinoma, the vaccination against HPV virus, and against cervical cancer and oropharyngeal cancer, vaccine against HPV virus has been proven to have a preventive role. This is a well-known actress, Angelina Jolie. She had a high risk to develop breast cancer and ovarian cancer. Her mother had ovarian cancer, so she checked her risk factors by genetically testing herself, and she found out that she is at a high risk for cancer. So she prevented cancer by removing both her breast and ovary. So surgery has got a preventive role in cancer also. So those patients who carry a high risk of developing breast cancer in the future, we have surgeons have a role to play in preventing cancer. There are options available, and for a BRCA1 and BRCA2, we recommend bilateral mastectomy with reconstruction and bilateral mastectomy with oophorectomy in those patients who are prone to develop ovarian cancers also in BRCA1 and BRCA2. And in medullary cancer patients with a familial tendency or a proven mutation, the thyroidectomy has got a proven role in prevention of cancers. And in those cases with polyposis syndromes, total proctocolectomy has been proven to prevent cancer. So surgeons have also got a role in cancer prevention. So a small case scenario, a 40-year-old female with small breast lump, 2.5 centimeter breast lump without any axillary nodes. It is an early stage cancer. Previously, we used to go for MRM. Now, this patient, imaging was done, which showed a small tumor of 3.5 centimeter with the nodes which are clinically not palpable. Biopsy was done, which proved that it is a good prognostic tumor, ERPR positive. The distant screening showed no metastasis. This patient underwent a breast conserving surgery with an oncoplastic technique and a SL and sentinel node biopsy. Nodes were negative. So this patient nodes were sent for frozen section analysis. All the nodes were shown to be negative. So axillary dissection was avoided. And the final biopsy showed margins are also free. So this patient final pathology also showed that tumor is an early stage tumor. So this patient had an option to conserve the breast, so which we did. So this is what we aim to achieve, to detect cancer early, to avoid a radical surgery, minimize morbidity, and prolong lifespan as we intend to. So this is my end of the talk. Thank you for patient listening.
Thank you, Vijay sir. It was a very good lecture, extensively covering all subjects. So the forum is open for discussion. Any questions? Please raise your hand. Nothing has been posted yet, sir.
Yes, sir. Basically, as an Asian, we are inherently protected because of our skin tone. The limit of sun exposure per se, there is no prescribed time duration limit. But if we go to extremes of latitude, because the incidence of sun rays, I mean, the angle at which the sun rays fall, those sun rays are more carcinogenic than those sun rays which fall at the or close to equator level, because we are close to equator level. So our skin per se is protective, and our location, geographical location, is better protective compared to extremes of latitude. So there is no clear-cut guideline as set to say you cannot stand in the sun for more than 1 hour or 2 hours. So if you go to extremes of latitude, wear sunscreen. It is not limiting sun exposure, it is protecting yourself from sun exposure. So wear sunscreen, wear full sleeve or closely covered clothes, wear wide brimmed hat. These are all recommended. There is no clear-cut guideline that do not stand in the sun more than 45 minutes. No, not like that. But protect yourself from extremes of exposure by using adequate protective measures.
Chances of hepatocellular carcinoma. There's a question from the audience. Chances of hepatocellular carcinoma, familial incidence of hepatocellular carcinoma.
Hepatocellular carcinoma, familial incidence is close to around 5%. In Indian population, it is as compared to the other Asians. Mostly hepatocellular carcinoma is the highest number is seen in Southeast Asians and in the Western population. Indian population, the familial incidence is less only. It is 5% or I don't know the exact number, but it will be less than 10%, definitely.
About serum PSA and CA prostate.
Serum PSA is a proven tumor marker for prostate. It is widely used for screening. But nowadays, the role of PSA in screening is uh, being debated in these forums. Some countries have suggested that should be stopped. But serum PSA is a good marker for both prognostication as well as to assess the tumor recurrence also.
Role of flow cytometry in leptomeningeal lymphoma.
Being a surgeon, uh, I have limited knowledge about lymphoma. That
Yes,
to
sir.
leptomeningeal lymphoma, I have no knowledge.
Okay. Chance of recurring Hodgkin's lymphoma.
Hodgkin lymphoma is one of the good type of lymphoma. Chance of recurrence is still there, but it is highly curable with the available treatment regimens and with the available salvage regimens. We can even do an bone marrow transplant also, even if it recurs. So chance of recurrence is there, but even with recurrence, the chance of cure is high.
What about immunotherapies one? Like in which carcinoma they are not mentioned, but what about immunotherapy?
Immunotherapy is another big topic. Immunotherapy is coming up in a big way. Uh, we sensitize the existing lymphocytes of our body to attack the cancer cells. There are several ways to do it. So we have vaccines also. We have CAR T cell therapy where the cells, lymphocytes of the body is taken out. It is sensitized against the cancer antigens and then reintroduced into the body. So immunotherapy is a broad term. There is not
Yes, sir.
a single drug or a treatment modality in immunotherapy. There are several interleukins which are used to stimulate the body's immune system to attack tumor cells. And there are several molecules available nowadays, which will stimulate the body's own immune system to attack the tumor cells.
Okay. So one last question, sir. What about tumor markers for pancreatic carcinoma?
For pancreatic carcinoma, the commonly employed tumor marker is CA19-9. This is also used for in extrahepatic biliary system also. So CA19-9 and CEA are the two commonly used tumor markers for pancreatic cancer.
Yes. So thank you, sir, Devaskar, sir.
Thank you, sir.
It was an excellent presentation, and we had some lots of interesting questions also. Thank you very much for your kind, sir. So the next speaker for the day is Professor Dr. Sridhar Subbiah, Chief of Endocrinology, Madurai Medical College, and I request Dr. Sridhar to start his session.
So good evening, respected physicians, and I would like to thank the IMA of Tamilnadu State Branch for giving this opportunity, and a special thanks to Dr. Anand Chokalingam sir for the invitations. And I will be discussing regarding the how to choose an OAD in the current era. And so I'll be discussing the various oral anti-diabetic drugs that is currently available, and based on the which category we can use it, and regarding the multiple aspects, I will share the views, pros and cons of each OAD, and so that it will be beneficial. Since the prevalence of diabetes is enormously increasing, and almost every household, at least one of the family members may be affected in our household, at least diabetes. So as a physicians or practitioners, we should aware about the diabetes and its complications so that we can choose the drugs. And the prevalence is almost 10 to 15% depend upon the various urban and rural studies across the Indias. So almost 20% prevalence is very high numbers, and many of the cases is still undiagnosed, and maybe screening is less effective in the interiors of the part. So among the oral anti-diabetic drugs, there are a lot of options are available, starting from metformin and sulfonylureas and gliptins, DPP4 inhibitors, SGLT2 inhibitors, and glitazones, and recently maybe imiglamin. That is one of the latest additions in additions to the existing therapies. And in spite of all these, lot of drugs are available in Indian markets, and nowadays generics also available. In spite of all these things and fixed dose combinations, the mean HbA1c is very poorly controlled as comparing with the Western populations. So you see that in Western populations, more than 70 or 80% HbA1c, they are able to maintain less than 7. Whereas in Indian populations, the mean HbA1c are more than 70%. The HbA1c is maintaining between 8 to 9. In spite of physicians, we are easily approachable, and lot of the cost effectiveness of the drugs and the combinations of therapy, in spite of the multiple benefits, the Indian diabetic controls is not so much like the Western population. So we have to go in a longer way for the better glycemic controls, so that it will be more effective to prevent the complications and improve the quality of life. So ultimately, all the diabetic drugs and they are more focusing about good glycemic control and ultimately reduce the complications of type 2 diabetes. That was the things. Yeah. Slide more. Slide is. Yeah. Change it up. So how to choose an balanced view? It's not. Yeah, keep moving. So I'll be discussing regarding this, the pathogenesis of diabetes, and what are the drugs and factors, what are the factors that determining the choice, and glucose-centric to, yeah. So this is the pathogenesis, and you see that almost there are multiple ways or multiple pathogenic mechanisms. So the strong predisposition is genetic. So, and the Asian Indians, we are more prone to have type 2 diabetes as comparing to the other populations. So the gene is an important thing. In addition to the genetics, lot of the family history and the environmental factors like the dietary patterns. And as age advances, everyone is prone to have more diabetes. Some people may thought that beyond 40 years or 50 years, it doesn't happen. So age increases, the chance of development of diabetes is more. So at least once in 3 months, we have to keep checking the HbA1c. So with the genetically background environment, whenever there is a insulin resistance and beta cell dysfunction, that is a two important pathogenic mechanisms. So in previously it was thought that insulin resistance alone was a culprit or causation of type 2 diabetes, but there should be a beta cell dysfunctions for development of the diabetes mellitus. Keep moving. So this is as comparing to the Western populations, we have the onset of diabetes is young, and the mean HbA1c at presentations is almost 8 to 9%. And we have low BMI or normal BMI, but still we are having more high risk because of the more and more visceral fat. And we have high postprandial glucose load as well as a high carbohydrate and defect in the beta cell dysfunctions and the financial constraints, even though we have the cheaper as comparing to the Western population, but still some of the populations are unaffordable. So these are the various reasons, even though as comparing to the Western populations, Indians are more prone to have diabetes and more poor glycemic control. So skip it. So we keep checking, and why we should target or control the glucose. So this is the three major important organs. If uncontrolled diabetes, almost it leading to the various complications, maybe the vascular endothelium, or maybe the heart, or maybe the renal. So the catch is this thing is pipe, pumps, and filter. So we have to if prevention is the better way. Once all these complications are developed, many of the complications are irreversibles. So already happened is happened. So we have to target the prevention aspect as comparing to the treatment aspect. So this is one of the summary of the complications. And fortunately, these microvascular complications are reversible, like early stage of diabetic retinopathy or diabetic nephropathy or neuropathies. And most of the macrovascular complications predominantly irreversible. So we have to, again, prevention, then only we can improve the quality of life. So once the macrovascular complications developed, many of the times it is irreversible in situations and it affects the quality of life also. Next. So this is the well-known data. So each 1% reductions in the HbA1c will give the dramatic benefits over the death from the morbidities and mortality, and improvement in the coronary events, and reductions in the microvascular complications as well as the peripheral vascular disease. And we have to aim at HbA1c of less than 7. Next. So this is the, keep moving. So this is the slides. It shows the all pathogenic mechanisms, the different pathogenic mechanisms, and the popular one is ominous actate. So the different pathogenic mechanisms being playing a role in type 2 diabetes development as well as the complications. And you see that the first and foremost, that is a sulfonylurea. You see that sulfonylurea predominantly acting in the pancreatic beta cells. So it targets the pancreatic beta cells. And the second one is a DPP4 inhibitors. Again, it targets the beta as well as it suppresses the glucagon, alpha cells also. And third one is a metformin. And metformin, it targets the liver basically and fasting hyperglycemia. And the fourth one is alpha glucosidase. It's acting on the gut as well as incretins. So it suppresses the the gastric peptides. So the incretins and alpha glucosidase, it's again targets the gut. And fifth one is the glitazones, like pio and rosiglitazones. It targets the skeletal muscles as well as the liver. And the sixth one is the AGL2 inhibitors. And seventh one, again, muscles. Again, it is glitazones and metformin. And the bromocriptins and hydroxychloroquine. So these are the what the main important thing I want to highlight it here is always use the combination therapy, because more than one mechanisms are being playing an important role in development of pathogenesis. So knowingly or unknowingly, we use the combination therapy. Two different mechanisms are being targeted and achieving rapid glycemic control. In previous days, maybe 1 or 2 decades, you start with one drug, you escalate to the maximum dose of that particular drugs and go for switch over to the second drug. So nowadays, combination therapy, so we target the multiple pathways at a single pill. So that was the current situations and the guideline recommendations. And this is the summary. This will be of what I am going to discuss 2022 from RSSDA and 2024 in the ADA. This is the latest update about all this glycemic control. So before the drugs, emphasize about the lifestyle and healthy eating behavior and maintaining the body weight and blood pressure and lipid levels. So this is the holistic approach. And when one important thing is sleep. So always have to ask about the sleep, and 6 to 7 hours sleep is essential. And shift workers, unfortunately, they have poor glycemic control and more high risk. So we have to emphasize about all the things. Next. So these are the journey of the oral anti-diabetic drugs. So during the World War, sulfonylurea was invented, and subsequently, previously just before that, metformin, and later the glitazones and alpha glucosidase inhibitor, and DP4 inhibitors is almost 20 years now, and AGLT2 inhibitors is almost 10 years now. So almost most of the drugs are time tested, and since the starting of the invention, it is being tested. So there is no doubt about usage of these drugs, and particularly we have to choose the patients to use which type of drugs. And so this is the almost whatever guidelines, maybe Indian guidelines or Western or European guidelines, any guidelines are using the metformin is still the time tested drugs for the monotherapy or initiation of the therapy, particularly in early stage of diabetes. And yeah, so this is just before. So metformin, it has even newer mechanisms also. Basically, it acts in the liver and it decreases the hepatic glucose output. So it is one of the important drug for fasting hyperglycemia, and predominantly it acts on the liver. So the fasting hyperglycemia will be very well addressed with metformin therapy. And so it start with low dose, start with 500 milligram twice daily. Initially, you may start with after food, and subsequently patient tolerated, you can change over into the before food. And even though the guidelines recommend up to 2.5 gram, every visits you keep asking about the tolerance of the metformin. Some patients, they may be well tolerated with 1 gram. Some patients may be up to 2 gram. And you have to notice about intolerance to metformin also. Some percentage, maybe less than 5%, there may be acid peptic symptoms or maybe diarrhea following the metformin. So you have to identify the gastroparesis or any acid peptic symptoms, so that we have to avoid metformin. So if you clinician fail to recognize the metformin intolerance, ultimately the patients go to the alternative medicine. So we have to more aware about the metformin intolerance also in some subgroup of patients. And this is the up to what stage we can use metformin, even though it can be recommended, but in Indian continent, you have to be more useful, and the patient should be good compliance, and periodically they should checking the serum creatinine otherwise. And so better whenever you are using the EGFR is well and good. Otherwise, if any creatinine of more than 1.3 or 4, according to the age matched this thing, you have to keep monitoring the serum creatinine, and whenever is a borderline category. And so patient is in poor follow-up or unable to check the creatinine frequently, and you better avoid and be careful about usage of metformin in critical conditions like EGFR less than 60. Otherwise, they may be end up into the kidney disease, and whenever the predisposing conditions are there. Yeah. So the metformin is a foundation stone, and it has a pleiotropic benefits. Even obese individual, it is one of the best drugs, and no hypoglycemic risk, and is cost effective, and it is almost long-term safety. And regarding the sulfonylureas, and you see that there are two sulfonylurea, older sulfonylureas and newer sulfonylureas. And the older sulfonylureas, it's almost out of except the glibenclamide. And glipizide also is at some extent it's been used, but all the safeties has been demonstrated very well with the glimepiride as well as the glycoside. And so whenever you are planning to use sulfonylureas, the safest one is the glimepiride as well as an glycoside. And why? Just almost mechanisms are similar. It is acting on the beta cells of the pancreatic beta cells, particularly sulfonylurea 1 receptors, and depolarizations of the beta cell membrane, and it is, releases the insulin. So whether the patient is taking diet or not, it keeps acting. That is irrespective of the diet, this sulfonylurea will work. So the chance of hypoglycemia is there in sulfonylurea. And all are not different, same. So there are some similarities and some differences is there with the sulfonylurea. And I will be touch upon just 2 slides regarding the CV safety as well as the renal safety, and hypoglycemia, beta cell apoptosis, and weight gain. So these are all more common. The last 3 is the older sulfonylurea like glibenclamide. So as much as possible, not to use it glibenclamide because of this the chance of hypoglycemia and beta cell exhaustions. And newer sulfonylurea, again, it is quite safe. So you see these sulfonylurea structures. So the first one is a glycoside. And there are 2 moiety, sulfonyl moiety as well as the benzamido group. So whenever the glycoside, as comparing with the other sulfonylurea, has a different structures, and it's a cardiac safely sulfonylurea. So whenever any sulfonylurea you want to use it for the glycemic efficacy, the best sulfonylurea is a glycoside. And subsequently, there is a glimepiride also is a better sulfonylurea. Next one. And the glimepiride has higher rate of association and dissociations. In older sulfonylurea, they bind with long time for the sulfonylurea receptor, so the chance of hypoglycemia is more. Whereas the newer sulfonylurea like glimepiride and glycoside, they bind with a very short span of time. So there is chance of hypos are less as comparing with the older sulfonylurea. So it is a less weight gain and less hypoglycemic risk. And as already told that glycoside is safest sulfonylurea whenever we are using for the cardiac patients. And it doesn't acting to the cardiac myocytes. The cardiac myocytes has sulfonylurea 2 receptors. Older sulfonylurea will act on the SCR2, whereas the newer one will act predominantly in the SCR1 alone. So that doesn't cause the ischemic preconditionings or is a cardiac safety. Next. And this is one of the important practical slide. And you see that in textbook, there may be a maximum dose, but this the last part, you see that beyond some particular dose, it doesn't give additional benefit. For example, the last 2 things, glimepiride and glycoside, you see that the glimepiride, even though the maximum dose, we can use it 6 milligram. Beyond 4 milligram, there may not be any beneficial effect. And similarly, the glycoside. So always use the beneficial dose and not use the dose beyond that beneficial dose. So always is better than using this optimum dose, so that you add the other 3rd drugs or 4th drugs instead of hiking to the one of the maximum sulfonylureas. Next. So this is the one of the Lancet endocrinology this thing. So among the all-cause mortality and CV mortality, the safest, you can see the last 2, the glycoside and glimepiride. So whenever any sulfonylurea are using, these are the 2 drugs which is safe and cardiovascular friendly as well as all-cause morbidities and mortality. And whenever the renal part, the safest sulfonylurea again glycoside as well as glipizide. So the 2 sulfonylurea, even end stage kidney disease, you can use it is glipizide and glycoside. And glimepiride beyond 1 milligram is not recommended to use for the renal point of view. So, and this is the landmarks trial. You see that the safety about sulfonylurea, even though almost UKPDS, advance, adapt. So almost so many landmark trials are there regarding the safety of sulfonylurea. Regarding the recently also the Carolina trial, and it was comparing with the Lina and found to be CV safety also. Next. So this is about meglinides. It is repaglinides and netiglinide. Basically, it's a short-acting insulin secretagogue, and the structural is related to sulfonylurea, but it is short-acting drugs. Next. And only the easily available is a repaglinide, maybe a 0.5 to 1 milligram and 2 milligram it is available. So it's a short-acting drug. So it is most useful in postprandial hyperglycemia since it is not a long-acting drugs. So it is a ideal candidate is a high postprandial hyperglycemic individual and people with erratic food intake and renal dysfunctions also some way we can use it, and metformin intolerant we can use it. So coming to the gliptins, and so one of the beautiful of gliptins is a glucose dependent insulin release. So whenever patient is not on oral diet, this gliptins doesn't work. So the chance of hypoglycemia is less. So it acting through the incretins. So the glucose dependent insulin release from the beta cells. So it work on the only the glucose is available, and it is safer among, we can use it at any point of time without in elderly population more the safer drugs among the gliptins. So these are the available gliptins. Starting with sitagliptin, it is almost 2006 has been it has been used in the practice, and Vilda and Saxa, linagliptins and teneligliptin later came into the picture. So this is the dosage. So the Vilda is a twice daily dose, and Sita is a once daily, Lina is again once daily, and the teneligliptin again once daily. So always use this whatever the classical this thing. Beyond using even teneligliptin 20 milligram twice daily, it is not going to be beneficial. So instead of you add the other category of drugs instead of hiking the beyond the recommended dosage, it's not going to be beneficial and more harm rather than the beneficial effect. So again, all the safety has been well documented. So it is a cardiac neutral drugs. There may be a lot of landmark trial starting with the Savertimi, Examine, Ticos, Carolina and Carmelina. So whatever the this thing, it is a neutral drugs. So there is a by in elderly populations, you can use it. These drugs, it doesn't cause hypoglycemia and cardiac neutral. And next, and among the renal issues concerns, so linagliptin and teneligliptin, these are the two gliptins. Even with end-stage kidney disease, you can give this usage of gliptins. Now, Lina is a half-patented, so it is available with generic formulations also. So these are a lot of drugs is available with half-patented now, and so this is the boon to use in many diabetic populations. Just go back. So it's a safer drug next to metformin, doesn't cause hypoglycemia, and weight neutral, CV neutral, and only contraindications the pancreatitis. So in any previous history of pancreatitis or the pancreatic carcinoma, it is not been recommended, or calculus pancreas, fibrocalculus pancreatic individual also, better not to use these gliptins. Otherwise, it is a safer drugs. Next. So glitazones, pioglitazones and rosiglitazone, it is one of the drug for the NASH, non-alcoholic steatohepatitis or metabolic dysfunction associated liver disease. And this is one of the landmark trial, and you see that the pioglitazone safety in the cerebrovascular accident prevention. So it is one of the drugs due to the various reasons it was banned, and but it is one of the good drug provided you choose the correct type of patients. So it is useful in non-alcoholic steatohepatitis or metabolic syndrome associated liver dysfunctions, and mild to moderate kidney disease also you can use it. And whenever insulin dosage is very high and patient is not tolerating the metformin, you can use it, but always use low dose, 7.5 milligram, that is better. 15 milligram, if tolerates, no weight gain is there, you can use it. Otherwise, I preferably use 7.5 milligram once daily alone. And contraindication is morbidly obese individual, not to use it. People with postmenopausal with bone involvement, it is not a good drug for the bone health. So in 60 or 70 plus with previous history of fracture or severe osteoporosis because of some differentiations in the fat cells, so it is not been usage. And decompensated liver disease, it is not a good drugs. And people with volume overload status like congestive heart failure or anasarca, not to use it. And macular edema, proliferative diabetic retinopathy, it is contraindicated. So except these things, whenever insulin sensitizes we want and not tolerating metformin, you can use it along with any of these things. So we have to be balance it where to use these glitazones. Next. SGLT2, this is almost everyone might have seen lot of CME. Just I will skip it. Next. Keep moving. So these are the three SGLT2 inhibitors, DEPA, KENA, and empagliflozin. And the HbA1c reductions is almost around 0.5 to 0.6 percentage. So it is a very not a robust drug for the glycemic efficacy. Because of its pleiotropic benefits, it is being used. And whenever in severe insulin requiring patients, also if using these drugs, insulin reductions also has been documented. So it is because of its pleiotropic benefits, it is being used. Next. And weight reductions, it will be varies. Almost some patients, they may be 3 to 5 kg, and some patients even less than 10%, they may be up to 10 kg weight loss also has been documented. Some patients no weight loss at all. So it is an depend upon the genetic polymorphisms, you may expect some weight loss. Next. Next. So there are a lot of mechanisms. I will just skip it. Next. And not to be used along with diuretics, but it is better than diuretics, and it doesn't cause hypotension or intravascular volume contractions. Whereas you see the loop diuretics, it reduces the intravascular volume, and but SGLT2 inhibitors, it predominantly acting in the interstitial fluid. So it is safer than diuretics. So whenever usage along with diuretics, it's to be avoided. And it's almost safety trials has been well proven beyond doubts in almost all the things. So people with very high risk of heart failure or recurrent hospitalization for heart failure, even in non-diabetic individual, this is been recommended, and it is this molecule of this last decade. Next. So alpha glucosidase inhibitor, basically it is a disaccharidase inhibitor. What it will do is it prevents the very fast disaccharide absorptions into the monosaccharide. So it acting in the small intestine and it prevents the glucose absorptions, and it's break down the starch and disaccharide into glucose. So it basically it's delays the gastric absorption. That is the main mechanism of actions of this alpha glucosidase inhibitor. And currently we have acarbose and oglibose. And next. So it is being useful in obese, people with high postprandial glucose, and people with excessive appetite. So this is one of the drugs. Whenever patient is having more and more appetite, this is one of the drugs we can use it, and it also suppresses the appetite. And the last one is imiglimine, and basically it is similar to metformin, but some minor differences is there in acting to the mitochondrial dysfunctions. And it's 500 and 1000 milligram, it is available, and it has multiple mechanisms. So predominantly again, it also acting in the liver. And so it improve the insulin sensitivity, and HbA1c reductions is very less, only 0.5 to around 0.6 percentage. So next. So next. So this is the one of the important, you may remember as a mnemonic also, choice of the oral anti-diabetic drugs in multiple ways, starting from the age. So elderly populations, you use the drugs without causing hypoglycemia. Obese individual, you choose different drugs. And CKD, renal safe drugs. The duration of diabetes. So if duration of diabetes is more, always give priority to use sulfonylurea because it is more glycemic efficacy, established CVD, and financial. Almost now all the drugs are off patented. So it is almost similar, the cost, and you can use it any brand and whichever convenient. And glycemic status and hypoglycemic concern. So these are the simple mnemonic ABCDE approach of choice of the anti-therapy. And just next. So the elderly populations, metformin, DPP4 inhibitors, SGLT2. If no prostatic symptoms is there, SGLT2 inhibitors, you can use it, preferably use it in the morning hours. I saw some of the prescription for the night time. So night, there is a asthmatic symptom possibilities are there. So always use SGLT2 inhibitors in the morning hours. And if at all sulfonylurea in elderly populations, use glycoside, maybe a once daily, or low dose sulfonylurea or low dose glimepiride. That is a safer one. And obese individual, these are the best oral drugs like metformin, again SGLT2 inhibitors, alpha glucosidase, and DPP4 inhibitors. And renal safe drugs, linagliptins, among the sulfonylurea, glycoside and glipizide, and AGLG2 inhibitors, not to use it whenever the next. So duration, again, sulfonylurea will be a better choice. Next. So these are the recent concept, change in the concept from the glucose-centric approach to the patient-centric approach. Previously, all the guidelines focused regarding the glycemic efficacy. Now the guidelines focusing predominantly the individualized or the complication centrics, or what is the underlying individual is having the thing. So cardiac, this is a known slide. Cardiac individuals always use SGLT2 or GLP-1. Next. Next. So this is one of the important slide, and you see that whenever you are using any drugs, we choose the patients as almost I highlighted. So the age group, any GI symptoms is there, and renal safety, weight, and coexisting any fatty liver is there. So fatty liver is there, better use this AGLG2 inhibitors or metformin, or maybe this newer drugs of GLP-1 and other things. So in multiple ways you have to balance it. Next. Next. So among the oral drugs, sulfonylurea has maximum glycemic reductions efficacy. So keep it in mind. Next. And fixed dose combinations, it is available, and you can better compliance. It is the best drugs. Next. Next. I keep moving. And this is one of the important slides. So whenever patient is presented to the HbA1c of almost 7.5 to 8 or 8.5, use combinations therapy. And as already told, that targets multiple different pathogenic mechanisms so that we can get maximum glycemic benefits at a single pill or maybe 2 drugs. And whenever HbA1c of more than 8.5 or 9, and the triple drugs or combination therapy are always better, or use more than 3 drugs. And next. Next. And this is the natural history, and no one can predict when the patients will requiring insulin, but always our aim should be the yearly control and intensive control, and to keep the HbA1c of less than 7 or 6.5 as much as possible without making the individual hypoglycemia. And whenever the duration of diabetes is more than 10 years or something, we have to know about the initiation of insulin also. So at any point of time, patient is very poor glycemic control, glucotoxicity, weight loss is there, and always not hesitate to initiate the insulin. And nowadays, it may be a difficult situations. We have to keep counseling the patients so that we can use it the insulin at the next. So there I am just the last couple of slides, and there are different insulin options. I am just skipping. So this is an individualized approach, and again the same things. So each diabetic individual is different phenotypes, and we have to every time we have to assess the individual, and we need important of history taking. So more than the prescriptions, diabetic individuals, we need to speak to them. It is a more, and the entire family has to be counseled. And so every time we have to motivate and emphasize about all the drugs and the lifestyle modifications so that we can improve the quality of life. And next. So the multifactorial approach, already this is the summary of the, so in addition to the drugs, the lifestyle modifications, including the sleep, which is one of the essential things, and we have to focus it at every point of time. So the diabetes is a systemic disease, and previously it may thought that the glucose control or syphilis, it was thought as a systemic disease. And so if you know the diabetes, you know the entire medicine. So in such a way, it affects any systems of the body from the head to foot. So, and it has a variable progression rate. No one can predict how yearly they may be requiring insulin or how late they may be requiring insulin. So whichever possible in our hand, we have to focus and we have to emphasize it. So the benefits of yearly and intensive glycemic control, like making the HbA1c of less than 7 or 6.5 in a young diabetes individual, it has to be again and again emphasized. So we have to speak more and more to the patients and family members. And the glucose-centric approach to the patient-centric approach is the current recommendations to choose an oral antidiabetic drugs, and the multifactorial interventions. So not only we have to focus the glucose, we have to focus the lipids, blood pressures, and the physical activity, sleep, and dietary habits and everything to improve the quality of life. Not the by giving all the drugs, it's not going to this thing. Whatever time they are going to live, it will give the good quality of life, and so that is should be our aim and mottos. Next. So with that, I'm concluding. Thanks for the kind attention and opportunities.
Thank you, Dr. Sridhar, sir. Any questions? The forum is open for discussion. Any questions? So there's a question, sir, show me the slides of insulin doses.
So insulin dosage, yeah, just it is not a next.
Next slide.
Yeah.
Yes.
So basically, this is the whatever insulin you are going to use, you should know about the onset of action, peak, and duration of action. And whenever you are a beginner, use the long-acting basal insulin like Glargine or Degludec. This is the longer-acting insulin and basal insulin. It doesn't cause hypoglycemia. So whenever you want to use it along with the oral drugs, you start with low dose, maybe around 8 units or 10 units, maybe a 0.1 to 0.1 unit to 0.1 to 0.2 unit per kg per day. So you start with the low dose and escalate slowly and the basal insulin. And whenever you are initiating insulin, the insulin regimens will be simple. You can only single pricks or basal insulin is good enough. And whenever the duration of diabetes is more and postprandial glycemia is more, then you use the short-acting insulin. That is a basal bolus regimen.
What is the second line of drug in case of type 2 diabetes mellitus in teens?
In teen means
Teenage.
teenage. So nowadays, previously, any adolescent diabetes previously thought that it was of type 1 diabetes. Nowadays, we are seeing a lot of adolescent type 2 diabetes and maturity onset diabetes also. Strong family history is there. So the best drugs may be a metformin if it is obese individual. If non-obese or normal body weight, you can use it low dose sulfonylurea also, because we are not doing genetics for all the adolescent diabetes. If type 1 diabetes is ruled out, there is a no insulin requirement, or insulin requirement maybe 10 units or 15 units per day. You can use it sulfonylureas like glycoside or glimepiride. So that may be the, so next to the metformin, we can use it as sulfonylurea. And if it is any hypoglycemia risk is there, then you can go for even gliptins also. Nowadays, there's precision medicines that also been addressed. If obese individual, then go for SGLT2 inhibitors again.
Pregnancy and metformin usage.
So pregnancy, initially it was a fear was there, but nowadays we are using metformin in pregnancy. There is a no harm, and from UK it was being used in a very long time. And so if individuals before pregnancy, if on metformin, we continue metformin, and only things by using metformin alone, many of the times we may not get good glycemic control, because it's a metformin is a milder drug, maybe a 0.5% reduction HbA1c we may expect. And so fasting is glucose is very high, maybe more than 100 or 110. In spite of metformin, we have to use it insulin. So the metformin is a safe. There is no anyway. It is crossing through the placenta. It will be reached to the babies as well as to the breast milk also. Even though in spite of all these things, metformin can be useful, and but depend upon the glycemic situations whether to use metformin alone or you have to use insulin. Case to case basis, you have to take the decisions.
Reason for sudden rise in blood sugar in type 2 diabetes, receiving oral anti-hypolemic drugs and insulin.
So recent worsenings may be multiple factors, maybe a stress or sleep or coexisting any infections like tuberculosis, new onset, or any underlying infections, UTI, sepsis, and any inpatients hospitalizations or any steroid usage. So there are multiple reasons are there. You have to find out the history taking will be a most important things for a recent worsening of diabetic individuals.
Alpha glucosidase inhibitor, is it safe in pregnancy?
So except metformin, there is all are off-label indications. So there is no proven data are available. And in this current era, better not to use it. Other agents apart from metformin, or unnecessary want to challenge legally, and patients will pinpoint this thing, and so better not to use it metformin in these situations. Abba.
Yes, sir. So thank you, sir. It was very elaborate lecture and it was very useful for.
Thank you.
Thank you very much, sir. So I request the next speaker of the day, Dr. Sundar Chidambaram, interventional cardiologist from KMC Chennai, Kaveri Medical Center, Chennai. Sir, please.
Thank you. Thank you, Dr. Anand, and thank you, IMA Ramanathapuram. It's always a privilege to talk in front of my seniors, professors who taught me medicine, and also it's my hometown. It's always an emotion to talk a lecture in my native place. So first of all, my luck is always to talk in the last phase of the extensive lectures. Previous speaker talked on diabetes and he made everybody hypoglycemic, and also the dinner is ready now. And I'll be very short in my presentation. The phase of interventional cardiology now and then. So, see, to be on lighter side after a heavy lectures, you all know Telegram. So everybody are beyond 40s. Everybody will be knowing about the telegrams. Everybody might have seen the messages like Tata died, start immediately. This is the thing usually present. We used to see a lot of telegrams, and we receive the telegrams immediately. All the ladies in the house cry, and then finally we take a car. Finally, we go to a death ceremony, and finally the cremation happens. So this is the death thing ceremony happening previously, and the death technology has improved. So now what everybody says is just be in a Zoom, and the death ceremony happens. Everybody see from the Zoom call, and everybody cries. May not cry also, and this all happens in a death anniversary. So to be on a lighter note, the death technology has improved. So why not the medical technology? The medical technology also equally improved. So medical technology means I am just cornering to cardiology. So the evaluation of medical technology. See this point, the period has been more about what we should do, not what we can do. Because the technology is very vast. I can do whatever I want, but be keep that in your mind that what we should do. So this, with that introduction, I am going to the lecture proper. So the imaging. So first of all, the imaging, the history, you can see whenever ECG or echo is ordered in 1970s, you can see one fellow is keeping his leg in the tub. So usually the ECGs happen in bathrooms. So we have to have a lot of buckets, a lot of electrical instruments, and this happens there. So then now the technology has evolved so that that ECG machine has come like this, and CT machine has come like this, echo machine has come like this. And we can see with the echo, we can see the imaging of the heart, whether how it is contracting. I can see the heart of a fetus. I can see if there is an intervention happening in the heart, where I can see directly through the echocardiogram. I can see the echo, the heart in a 3D motion. I can see the heart with the transesophageal probe, with the probe nearer to the heart, I can see. So this type of evaluation has happened in the echocardiogram. So here comes the next imaging evaluation, that is the CT angio, and you can see the PET CT, and also the MRI has come. It has developed in a very, very larger manner. So, and coming to my interventional cardiac area, this is the heart. The heart can be divided into coronary arteries, valves, myocardium, aorta, venous circulation, defects, peripheral vessels. With all this, there are a lot of improvements and lot of innovations has happened in all these interventions in these areas. So I can go to the ASD. Previously, the ASD, if there is an ASD which is very large, everybody will ask the surgeon to intervene. Now, only very, very large VSDs, ASDs or VSDs are going to the surgeons. Now we have a device, occluded device. So we can easily put the device and the next day the patient will be discharged. So for the ASD, we have to assess the septum, all the we have to assess the size and we have to assess other structures nearby and then finally put this valve, put the device. So this is going to happen and the ASD is closed within minutes. So the second thing is SVC type of ASD. SVC type of ASD, previously, historically, it was sent to the surgeon because we cannot intervene through the device. But now the evaluation has happened. We can put a covered stent like this, and this SVC type of ASD can be repaired like this. So coming to the VSD, again, the VSD, if it is very large and if it is going to be subpulmonic, then the surgeon has to operate. And other type of VSDs like perimembranous or muscular VSDs can be easily closed with this type of VSD device. So earlier it was surgery. Now most of the VSDs are now closed with the devices. So coming to the PDA, and PDA also, earlier it was surgery. Now there are no PDAs treated with surgeries except for a very large PDAs or very crooked PDAs. Other things are closed with this coils, PDA, occluded device, everything. So coming to coronary arteries. So those are the pediatric or the adult congenital heart disease. Coming to the coronary arteries. The coronary arteries, everybody know, everybody might have come through, witnessed the coronary artery disease or coronary artery disease patients, and who will be sent for an angiogram, and then finally they will be finding some blocks, and which is very critical. If it is critical, we will be treating with the stent. So the stent technology has evolved a lot. So previously it was a bare metal stent, after that a drug-eluting stent, and the drug-eluting stent also has evolved into a very, very thin sized struts. And this is the very, I can say it is a boon to treat the coronary artery disease. You can see now there is a stent called bioresorbable stent. Earlier it was brought and then taken back because it failed, and now it has come back with an Indian company, that is the Miras 100, and it is whenever you put the stent, after 2 years it will dissolve. So only the natural artery will be there. So coming to the DEB, this is called drug-eluting balloon. Earlier we used to put the stent. Nowadays, why unnecessarily there is a metal jacket inside the artery? So we wanted to avoid, means now we have a drug-eluting balloon. Just the balloon will be coated with the drug, and we'll just dilate that area with the balloon and then with the drug-eluting balloon, and finally we can achieve this type of result, and it is going to be the future, and it is going to may replace the stent in many of the areas. So coming to the intravascular imaging. So what is happening inside the coronary arteries? I am curious to see inside the coronary artery what is there. Whether it is a calcium, whether it is a clot, whether it is a lipid plaque, then I can use an IVUS, intravascular ultrasound. You can see the ultrasound in a radiologist chamber. It is not that ultrasound, but the technology is okay, same, but it is a very, very thin catheter which can be passed inside the coronary arteries, and we can see the whatever it is inside the coronary arteries. So if you are very much bored about the black and white, you can go to the color, because the IVUS will be always black and white. We can go to the color. This is the OCT. We can see a very good color image. Then you can also see this. It's optical coherence tomography. You can see whatever inside the coronary artery with the colorful image. So calcium modification. Previously, if the coronary arteries are occupied with so much of calcium, we cannot break the calcium with a balloon, or we cannot put the stent. So those type of patients are sent to the surgery previously. Now there are a lot of innovations in the calcium modification. You very well know, the urologists very well know, to break the stone, they use lithotripsy. There also we are using the lithotripsy, that is the intravascular lithotripsy, where we can break the calcium and then we can put the stent. I am just showing what are all the innovations in that. We have a driller machine. So driller machine means it is called rotablation. Just when you on the driller machine, it will be rotating at a speed of 1,50,000 rotations per minute. It will just make every calcium as a sand, and then we can easily put the stent. This is called rotablation, and this is called as the orbital atherectomy. The rotablation will have a diamond chip in the front, but the orbital atherectomy has both a diamond chip in the front and the back, so that we can push, pull, and push, pull, so that the same type of calcium modification happens in our orbital atherectomy. This is what I said, the intravascular lithotripsy. This is a balloon, and we have a pulse chamber here. It will deliver the pulse, and then it breaks the calcium. It is a very safe tool, and we can break the calcium and put the stent. This is called intravascular lithotripsy. Then the fifth is the laser. So excimer laser, this also, it is a very small catheter. When you pass through the lesion with the calcium, and it can break the calcium, it can dissolve the clot, and this is one of the latest innovation, and it is promising. And coming to the opium balloons, whenever the calcium is very, very hard to break with a normal balloon, this is called the opium balloon. Opium balloon is a very strong balloon. It can break the calcium without rupturing the balloon. It is so strong. This is one of the latest innovation. Coming to if the clot, if the block is a calcium, whatever I said before was used, and if the block is a thrombus, we have a retrieval device or thrombosuctions. It can easily absorb the clot and make the artery open. You can see here, there is a full of clot, and this after the thrombosection, you can see a lot of clot being absorbed. So coming to the fractional flow reserve, what is FFR? If you see a coronary artery, if there is a disease, and if you are in a doubt whether this is a significant disease or a not significant disease, whether you want to put a stent, if there is a dilemma, use this FFR. If the FFR shows, if it is less than 0.8, then if the reading comes as a 0.8, then you have to put the stent. If the reading is more than 0.8, you need not put the stent. This is one of the latest innovation. You can see this lesion. After seeing the FFR, it comes as the 0.64. We have to put the stent. So likewise, lot of FFRs we have this thing. And then finally, a few slides about rhythm disorders. So coming to the rhythm disorders, like we have a lot of rhythm disorders like atrial fibrillation, ventricular tachycardia, everything. We have lot of devices, the EPs and devices. I'm not going to detail into that because it will be taking a long time. Because see how big is the pacemaker in 1950s. You have to carry like a backpack, like a pacemaker. It will not be inside the heart, inside the skin. It will be like a backpack. Now you can see it's like a bullet. So this is called micra. It can be just placed inside the right ventricle, and there is no wires everywhere. Nowhere there won't be any wire. So here the micra, it's a very, very tiny, like a bullet. It will be inside the right ventricle, and it will pace. And these are all some of the pacemakers. And coming to the myocardium. Myocardium, if the myocardium is very thick, that is one of the condition called hypertrophic obstructive cardiomyopathies. And when you inject an alcohol like this, then that myocardium will shrink. Then it is called as alcohol septal ablation. We are artificially inducing a myocardial infarction by injecting an alcohol into the septal artery. You can see the septal artery getting occluded like that, so that the area of the myocardium shrinks, then it helps in this type of obstructive cardiomyopathies. So the LV assist device, previously a lot of transplants were happening. If the transplant heart is very limited, we can use LV assist device. You can see there is a tube here. This blood from the LV will be sucked from the tube, and it will be delivered into the aorta. This is called the HeartMate devices. We can just place here, it will be inside, and these are all the batteries. It is all rechargeable batteries. Night he has to recharge the battery, and we have to remember that, otherwise he will not wake up again. So valves, coming to the valves, aortic stenosis everywhere. Now it is a booming aortic stenosis. Earlier it was a surgeon's domain because they used to operate. If nowadays we are just doing a transcatheter aortic valve replacement. So aortic valve replacement, some of the cases we have done now. And this is the valve we used to take through the aorta, and it crosses the valve like this. And then you can see the valve being deployed, and this is the final valve being deployed across the aortic valve. This earlier it was a surgeon's domain. Now we can do transcatheter. So through the femoral artery we can do it. And here comes the mitral stenosis. Mitral stenosis, you very well know, if the stenosis is not much of a calcium, not of a much of a commissural fusion, then we can do a balloon mitral valvotomy, so that the mitral valve will be opened with the balloon, and then we can easily treat this mitral valve. So here comes the transcatheter mitral valve replacement. Like the aortic valve we replace, the mitral valve also can be replaced like the transcatheter. Through the venous femoral vein we can insert, and this is the valve we can put it. So this is the transcatheter mitral valve replacement. This is called the transcatheter edge-to-edge repair. If the mitral regurgitation is like this, very severe, if the mitral valves are opening very widely, just put the clip in holding the two mitral valves. This is called as the mitra clip. So if it is clipped like this, so the mitral regurgitation will be reduced to from severe to mild. This is also one promising treatment for severe mitral regurgitation who are not operable. So here comes the tricuspid regurgitation. This is a trick valve. So if the tricuspid regurgitation is very severe and it is causing so much of edema, liver congestion, kidney failure, then this type of valves can be put like this, so that this valves will have a valve inside, so that the tricuspid regurgitation will be prevented from entering into the liver or into the SVC, so that all the signs of right heart failure will be nullified with this valve. This is called trick valve. So coming to the pulmonary valve, if it is a stenosis, we can do a balloon dilatation, or if there is a leakage, that is a pulmonary regurgitation, we have a melody valve like this, and it is very much used in pediatric age group whose the post-TOF repair, because those patients will always present with the pulmonary regurgitation. For them, we can put a melody valve. So coming to the future, few slides, and I'm just going to the LV devices. These are all in the investigation forms. If the LV, there is an aneurysm here, we can put this type of cup so that it reduces the LV volume and reduces the failure. This is also called as Aku clinch. This is a one clip like that. It can be put in the LV. And this one more intra-arterial shunting device. If the LV is very weak and RV is very weak, there is no further hope. We can put an intra-arterial shunt like this to treat these failure symptoms. So with that, I conclude my talk. Again, I am saying evaluation of the medical technology. This period has been more about what we should do rather than what we can do. I can do anything, but we have to remember what we should do. So thank you very much for the attention, and thank you so much for that.
So the forum is open for discussion. Any questions?
Yeah, because I purposefully left that peripheral vascular disease because of the dinner, and so I'm just sure. Because I see a lot of things. See, peripheral vascular disease we can divide into two. So, apart from aorta, every arteries are peripheral vascular arteries. So, coming to the leg, so if there is a non-healing ulcer, so if you are finding a critical lesion below knee, we have to put we have to open the artery, put the balloon, and dilate it. Never put the stent in the below knee arteries, because the below knee arteries, if you are going to put a stent, again it is going to restenose, and then again the patient is going for an occlusion. So above knee, if we have a lot of options like superficial femoral or a popliteal artery. So we can do it a balloon dilatation. If the results are very good, I can leave it, or other we can put a stent. And there are stent which are a lot of peripheral stents are available. So unfortunately, the peripheral stents are not drug eluting, so like a coronary stents. See, the coronary arteries, I can say it is an open forum, but because the medical technology, the cardiac technologies are funded with a very huge funds, but not in the peripheral arteries, because that's why the innovations are happening more in the cardiac rather than the peripheral arteries. The third thing is, one precaution we used to say is to never put the stent in the flexible areas like a popliteal artery or in the hip, the femoral arteries, because when you bend or sit, then the stent will break. So that those are all the some of the precautions we have to take. And lot of innovations, like same the intravascular lithotripsy also can if the arteries are very calcified, we can use the intravascular lithotripsy there. And also this drug eluting balloons are promising in this leg arteries, because we don't have stents, but we have drug eluting balloons which are lengthier. We can easily put that. So these are all the some of the things. Even laser can be used in the peripheral arteries, and these are all the things which are happening in peripheral arteries.
What is the drug used in drug-eluting
Lot
stent?
of drugs like zoltrolimus, everolimus, and sirolimus, and all are antimitotic drugs. So that never think like drug-eluting stents are done for preventing clotting in the inside the blood, inside the stent. These are all the drugs are eluted, which will be eluting for the first 30 days or 45 days maximum, because once you put the stent, there will be a tissue growth inside the stent, because the artery wants to heal. So it binds the stent with the tissue. So in order to prevent that tissue growth, that drug-eluting antimitotic drugs will help. That is the first 45 days. Then that is the drug-eluting stent. That is the zoltrolimus, everolimus, sirolimus, whatever, because there are individual differences between those drugs, but overall, all the antimitotic drugs are effective in preventing the restenosis. That is the tissue
Role
growth.
of CT calcium score from cardiologist, interventional
Yeah,
cardiologist point of
that's
view
a
is
good
asked.
question. Actually, it is a very vague thing, calcium scoring, because you see, everybody after 40 will have a large amount of coronary calcium. That doesn't amount to there is a blockages inside the heart, because naturally the adventitial calcium will be there. Adventitial means outside the stent, outside the artery. So the calcium deposition will be happening after the age of 50. So if the calcium scoring is more than 100, the CT coronary angiogram is not going to be useful in that patient, because CT cannot penetrate into the calcium and see the inside the artery. So that's why we always say, if the calcium scoring is more than 100, go for, if you are suspecting a coronary artery disease in that patient, go for a conventional coronary angiogram. If the calcium scoring is less than 100, you can always do a CT angiogram without operation. Yeah.
That
That I have to find out a new guideline for those users.
no, what I'm saying is it happening
Yeah,
really.
yeah,
I heard from one of my
you're right.
friends.
You're right.
Like,
See, so I actually, if you are owning a CT scan center, it is good, I think, because I'm not owning any center. And see, I'm coming to seriously. See, CT angiogram, so whether it is going to be useful or not. So it's a very clear-cut thing, because so based on the risk-benefit analysis. So if you have a patient of 40 years or 45 years or 50 years, if the patient has any symptoms of cardiac symptoms, we have a battery of investigations for them. So if the patient is, patient is going to undergo ECG, echo, treadmill, and if the treadmill, if he has cleared, and if the symptoms are not only atypical, I am not going to subject him for a CT angiogram. If the treadmill is equivocal and I am not only satisfied with the treadmill, I am going to subject the patient for a CT angiogram. Or second thing, if the patient is not able to do a treadmill, and if the age is less than 60 and the coronary calcium is less than 100, then I will subject the patient for a CT coronary angiogram. See, what Dr. Anand was saying is, merely doing a CT angiogram, to see whether I am having a coronary artery disease analysis or not is not indicated as of now. It is a class 3. So even though some of the doctors might have said post COVID, because to do a coronary angiogram, because a lot of younger deaths or younger MI was happening, in order to find out earlier, we can ask the patients to do a coronary angiogram. But still now the guidelines is not as such. But if you want to do, because there are a lot of negative aspects of the CT angiogram, because the radiation is there, you're going to use a 90 ml of contrast. These are all the things. But still, as per guidelines, it is not indicated for a asymptomatic patient to undergo a CT angiogram. This is my take.
Yes, sir. So thank you, Dr. Sundar. It was a very elaborative, recent developments, and many people are giving a comment that it was very informative, very brief, and it was very knowledgeable. So thank you for coming all the way from Chennai. Thank you,
Anand.
Sundar. Thank you.
So I think we are coming to the end of the very exhaustive session. I've been sitting from 3 o'clock, and now it is going to be almost 9. Before we give proposing the vote of thanks, I request our Secretary, Dr. Joseph Rajan sir, to honor our President-elect Sridhar sir. He's also been sitting for the 6 years, patiently listening. Sir, please.
Hopefully, it will give me some guidelines how to lose weight.
I request Dr. Sridhar sir to honor the speakers who are present in line. I would request Dr. Vijay Bhaskar sir, please. Then I request Dr. Sridhar sir, please. Dr. Sridhar receiving from Dr. Sridhar. No. I request Dr. Sundar, please. Thank you, Sridhar sir. So, on behalf of Tamil Nadu State Branch CGP and also on behalf of IMA Ramanathapuram, I would like to thank our State President, Dr. Abul Hasan sir, our State Secretary, Dr. Karthik Prabhu, who came all the way. He had an emergency, so he had to leave in between. Our President-elect 25, Dr. Sridhar sir, and all the members who are online, Dr. Gunasegaran sir, Vice President of National IMA, and Dr. Senguduvan sir, President-elect 24. And I also would like to thank our CGP office bearers, Dr. Rajesh from Salem, Dr. Madan from Vellore, and Dr. Sendil, who is the chairman of studies of CGP Tamil Nadu. Not but not the least, now it is almost 9, and there are around 77 registrations. Until now, 500 people were online till now. And I would also like to thank our Ramanathapuram branch secretary, Dr. Joseph Rajan sir, Dr. Arindra sir, our president, Dr. Ariyullan, our treasurer, for having taken pleasure or pains in organizing us. Yes, sir. And also whole. Okay. So, and I also would like to thank the Vice President, Dr. Khalil sir. He also left for an emergency to Madurai. So, he is the Tamil Nadu State Branch Vice President for our South Zone. So, he was also there here. Not but not the least, I would like to thank all our members who are present in person for this meeting. With this, we'll conclude this meeting. Thank you, sir. So apart from this, the main thing is the people, they have come all the way from Pondicherry, our audio visual people, SS Media Tech, and they did a good job by not preventing. I would like to thank Ram Kumar, Praveen, and all his team members for this. Thank you. And the dinner is ready. Sorry, I made you wait all long. Thank you very much. Thank you.